So it's my pleasant duty to introduce Dr. Arun Pajaniappane. Is that a correct pronunciation?
So you are as much of an expert in French as I am. And you don't pronounce the E, and this is actually written in French. So once you say in
It's
French, you
written
don't
in
pronounce the E.
French.
It
Okay,
is.
fine.
It is.
So
So it's
Pajaniappane.
Pajaniappane. Yes.
Okay, so Pajaniappane, who is a consultant audiovestibular physician and practices in the prestigious Harley Street of London in a Harley Street audiovestibular clinic. And he has dedicated training and dedicated interest in neurotology. And he's an extremely personable, bilingual, or maybe maybe four linguals by now, because I can definitely think of two Indian languages which come in naturally and two Western languages. I'm sure you know others. But somebody who, in the brief interaction which I've had with him, has become a good friend, if I may take the liberty of calling you that.
Oh, thank you.
We also have with us Dr. Sudhir Kothari. Dr. Sudhir Kothari, as I was saying, was in the college which I did my undergraduation, and I still remember he had long locks of hair when he was an undergraduate. And he was the university topper in almost every exam. And no surprises, because usually the toppers go into neurology, internal medicine and neurology. And he followed that path and made a good name for himself in Pune, practices in Pune, extremely busy clinic, and has a special interest in neurology. And I think he's the ideal person to embellish this meeting. So without wasting any further time, Dr. Arun, the stage is yours. You could present your cases. And the way we run it is you can present and we'll have a discussion between you, Sudhir, and me for about 15 to 20 minutes or half an hour at the most. And then we'll open it up to a discussion in general about the topic. So, Dr. Arun.
Thank you so much for the introduction, Dr. Ravi. And let me first and foremost share my screen, and then I can talk as we go along. Can you see that hopefully nice and clearly?
Yep.
And hopefully now it'll be on the full screen. Yep. Again, I'd like to really thank yourself, thank Dr. Sudhir, thank Niranjan and Cyclops, particularly to facilitate this and inviting me to present here on the esteemed Grand Round. I think I've known Cyclops and Niranjan since the beginning, since the early days to a certain extent, and I was very proud of the amount of work coming from my homeland. And I am, as in all intents and purposes, been living in the UK for a long time, but I'm still born and brought up in India. So it does always make me proud to support Indian initiatives and ventures, and particularly in the scientific world, which I'm involved in, which makes me sort of very happy and proud. So again, thank you for inviting me. So those are my various, if I go back there, those are my various affiliations, which I have to officially declare in most of the talks that I give. And I work in different capacities with different organizations. But I am an audiovestibular physician, and most people don't know what that means. And I always put in a slide because actually it's quite unique to the United Kingdom. As I was explaining to Dr. Ravi, initially I trained as an ENT surgeon, but because it's a long convoluted pathway, halfway through you can branch off and actually specialize, and not so much as a subspecialty, but as a separate specialty on its own. In the United Kingdom, where there's an established training program of about 5 to 10 years, 5 years, 5 to 10 years, 5 years maximum, in addition to the existing ENT training. And we cover all the other aspects that don't get covered in ENT. So for example, the neurology training that I underwent wasn't quite so much neurology as a whole, but under the leadership and tutelage of Professor Bronstein, who many of you may know, who was my tutor and mentor, and I worked for him for a while and did research projects for him. The other aspects, such as pediatrics, such as general medicine, psychology, is all part of the training pathway. But in essence, it's a small niche medical specialty, and it is something which I do advocate in the wider field and wider world, as it kind of gives the homogenization in terms of training rather than ad hoc training. But without further ado, I shall go on to the cases. And the first case is an interesting case of acute vertigo. Now, unfortunately, I don't have any videos of the acute vertiginous presentation, but I'll do this in a slightly different way, because maybe we can interact together with Dr. Sudhir and Dr. Ravi. I shall start off by presenting the audiogram or the investigation findings, and then we can talk about potentially the causes of what caused what resulted in this presentation. So this is a lady who presents with, as you can see, unilateral, acute, profound sensorineural hearing impairment. Left side was completely normal. And this is her caloric test results, again indicating a right-sided vestibular loss. So here we have a case of an acute audiovestibular loss in the context of the fact that we are doing a presentation on central vertigo. So, you know, it's unlikely to be labyrinthitis. So any immediate thoughts, Dr. Sudhir or Dr. Ravi?
ICA territory ischemia or infarct.
Absolutely, absolutely. So it's the one that we always worry about, isn't it, when we look for acute labyrinthitis type picture? Is it something which is more central? Is it a ICA infarct? And so, as I mentioned, I'll do this a slightly different way around just to promote discussion. So what is the actual history? And I'll get back to the picture in a second because that's quite interesting. So it's a 21-year-old female who walked into the emergency department with sudden onset acute vertigo, nausea, and vomiting. And she doesn't live too far from the actual center, so she was able to get transported in by her mother. She reports reduced right hearing, and although, you know, in an acute phase, it's very hard to get that history. In her case, it was so obvious that she presented with vertigo, nausea, vomiting, and this right ear completely being gone. I do recommend always asking people about the hearing. And when we examined her, she had this left beating nystagmus. As I mentioned, unfortunately, we don't have the acute videos. And she was head thrust positive to the left. And what the giveaway to this was that it was something a bit more than labyrinthitis, was that she started getting a progressive right-sided facial nerve palsy. And we were lucky, as I mentioned, where we saw her relatively early and she walked into the waiting room. That was the ChatGPT's representation of someone with acute facial nerve palsy, although it can't seem to understand the difference between right and left. Though that would be an interesting one to put in. So the sort of next steps of the story was that whilst she was in the emergency department, she unfortunately collapsed with a GCS of 4. So that pretty much requires immediate intubation and ventilation. And we do have very good acute emergency services in the UK, and certainly at St. George's where I work. And so she was pretty much treated immediately, intubated immediately, stabilized immediately, given the appropriate acute treatment, I think including stabilization of blood pressure and possibly mannitol. I can't remember the exact details, but we're not getting into too much of those details here. But in essence, she was stabilized. And the next steps was that we did imaging as a protocol. And the first line imaging in this kind of scenario is always a CT head, only because it is readily available. MRI scans take a bit longer and sometimes not always available, even though it's the daytime. CT head was performed. And lo and behold, it did show evidence of a right ICA territory aneurysm with a rupture and bleeding into the internal acoustic meatus. So very much in keeping with what our esteemed colleagues here immediately knew about. So what did we do? Well, we'll talk a little bit about the vascular anatomy, just to make sure, in case we wanted to make that sort of very clear. The anterior inferior cerebral artery, comes off the basilar artery, and from that you also get the labyrinthine artery, or the internal auditory artery, which can accompany the the vestibular cochlear nerve. So any bleeding or infarct in this territory can potentially lead to acute unilateral audiovestibular loss, very much similar to a labyrinthitis type picture, although it is very much a central rather than a peripheral disorder. And the next steps in this particular case was that she underwent an embolization procedure. So this was approached via the groin. Again, St. George's has got a very good neurology unit. It's got a very good, I think, cardiologist who particularly performed this procedure. But whoever ended up doing the procedure did a grand job. They got in there pretty quickly. They managed to stop the bleeding. They managed to embolize the artery. They stabilized her. She did well. She stayed in ITU, bearing in mind that she's a young and fit and well patient. Otherwise, she didn't have anything else going against her. She made a good recovery in the grand scheme of things, considering this could have led to much, much more worse fatal outcomes. And I think that's where we came in, because when she was discharged from the intensive care unit, eventually, this is a lady with acute unilateral audiovestibular loss, with severe ataxia, difficulty with mobilization. She's been working with the physiotherapist. She's got unilateral hearing loss. She's got unilateral tinnitus. She had this facial nerve palsy, of which needed to be all addressed in its holistic sense. And again, our colleagues are very good in order to refer patients appropriately to our service. And when I first saw her, this is where I did manage to capture, in clinic this is, capture her eye movements. I thought it would be worthwhile sharing because it was very interesting. And again, this did promote some initial discussions between myself and my colleagues as to what the nature of this was, because by this time, as I mentioned, we'd known that this was a ICA infarct, that we were expecting an audiovestibular loss. We were expecting eye movements in keeping with that. So hopefully you can see this nice and clearly. So this is without visual fixation. This is on primary gaze, and you can see immediately there's something slightly unusual. And we'll discuss that a bit further, but I'll let you view the video in the first instance. And then I normally do head shaking, and this is the head shaking maneuver that she's performing. And just to put that in perspective, that's the right, that's the left, if you can see my mouse. As I said, I normally at this point open it up for discussion. Dr. Khatari, Dr. Ravi, any thoughts from both your perspectives on those eye movement findings, which, as I said, initially prompted a fair bit of discussion amongst myself and my colleagues because no one was able to figure it out as to.
So this is interesting. One would have thought that because if it was only labyrinthine affection, you would have got nystagmus unidirectional beating towards the right.
Correct.
And beating towards the left with the, beating towards the right. And
Yeah.
it should have been unidirectional. But you are getting a gaze evoked nystagmus. When she looks to the right, nystagmus is beating to the right. When she looks to the left, it is changing direction. So this is this suggests that there is also probably a brainstem infarct. And we know that the ICA also supplies the pons. So probably she also has a pontine infarct, which is causing the additional gaze evoked nystagmus in addition to this. So this would be something like a Bruns nystagmus, where there's a combination of gaze evoked as well as vestibular sort of nystagmus. So on the right, it is coarser and slower. On the left, the jerks are a little faster and shorter. So I would call this Bruns nystagmus.
So thank you, and very much so. I think you've kind of been spot on to a certain extent in terms of we have this bilateral gaze-evoked nystagmus, which is very much, I think, if we classify it broadly, it's a very central sign, and it's more to do with the brainstem or the cerebellum. She also has this consistent upbeats, and the reason I played it again, because when we did the head shaking, the vestibular asymmetry also comes into play a little bit as well, and we can see that a little bit more where there's that left beating nystagmus. Even at rest here, we can see that tiny bit of a left beating nystagmus, which is what the traces eventually sort of told us. So a left beating, an up beating, and a direction changing gaze evoked nystagmus, which is what I've summarized on this slide here. And so we discussed that because we were just discussing how this can represent potentially a different underlying area affected. I broadly sort of categorized it under cerebellar eye movement signs, but as I said, it can be cerebellar and brainstem. Oddly enough, in her case, we sent her straight away for an MRI and an MRI with contrast, and this is the main thing that came back from that MRI scan. Is that in fact she had this cerebellar infarct, which became very obvious and was reported by one of our neuroradiologists because she was very involved in the case subsequently when we were discussing things with her, because nothing made sense. So we had to rescan her, and that's the first thing we did. And lo and behold, this is apparently a recognized complication of an embolization procedure, which has been reported in literature. And in fact, oddly enough, both the cases I'm presenting today doesn't seem to have made me many friends for whatever reason. So in this particular case, I flagged it up to the whoever it was, and I'm just sort of remembering back to who it was. But I think their ultimate answer was, well, listen, we saved her life. It's a recognized complication. We don't really care, in not so many words, but really, you can't argue with that, to be completely honest. You know, this is a potentially fatal condition, and a small minor complication in the grand scheme of things is a stroke affecting whichever part of the brain it is. And as I mentioned, it has been reported previously in literature that the embolization procedure can result in ischemic complications, possibly due to the embolic material or thrombus formation, or just the passage of the guiding catheter through the posterior circulation.
Dr. Arun, was the nystagmus, this gaze-evoked nystagmus seen before the embolization procedure, or it was not?
It wasn't seen or documented before. I mean, everything was, quite sudden. The initial presentation was very much an acute presentation. The main findings were the immediate peripheral vestibular asymmetry that we can identify, and the progressive facial nerve palsy was the only other excitement, which kind of gave it that central feel to the entire story until she collapsed. And hence, I think everyone was ready when someone did collapse in extremis, because you kind of always knew that was a possibility based on the presentation.
One more possibility which your the interventionist might be happy with is that when you have a aneurysm rupture and bleeding, it can often provoke spasm in that artery, and the spasm can cause infarction. So maybe it was not iatrogenic. We can give him the benefit of doubt.
Yeah, but I certainly did not make any friends by bringing it up, and I was bringing it up more for scientific interest rather than anything else. But I did unfortunately get quite a defensive answer. But all credit to them; they've done a grand job of saving someone's life, I dare say. And
what was the time interval between the presentation and when you saw?
So I saw her on initial presentation, and then I also subsequently saw her as an outpatient, but that was several months later. So the initial presentation was when she presented to the emergency department, and I'd sort of noticed the facial nerve palsy, but by then it was quite, everything escalated pretty rapidly.
So what was the status when you saw her the second time? When you showed us the gaze nystagmus,
So the
was there any progression or regression of symptoms, or what?
To be completely honest with you, the symptoms at that stage were that she was very ataxic. She had this complete right-sided facial nerve palsy. She had a complete hearing loss, and she was in quite a poorly state and being able to not mobilize, just having come out of ITU after several weeks stay. So she was at her worst at that point. And it took a lot of subsequent investigation, appropriate rehabilitation, etc., in order to get her to back up and running. And I think her recovery spanned at least 1 year of regular hospital appointments with rehabilitation, with auditory rehabilitation, including cognitive rehabilitation. And yes, it affected her mood. But the last time I always recall seeing her was on the way back from work, and she was out shopping with her mother without any sort of aids or anything like that. And someone who'd pretty much would have otherwise, I think if I speak frankly, would have died, was going on to lead a more fulfilling life with a smile on her face. I think it was quite a potent story for me.
Excellent. Nice case. When was the MRI done? How many days after the intervention?
So the MRI was done at about I would say about 4 to 6 weeks after the intervention. So she was initially the intervention happened very swiftly, immediately after the initial event, and she was in ITU for a significant amount of time afterwards. And only when she came back out into the outpatient types, the rehab scenario, did we see her again at that stage.
Yeah. So, I mean, just as a point, if an MRI is done in a day or two, one can time it. That is this an infarct 5-6 days old, or is it a 1 day old? But if it is weeks later, then 5 weeks and 5.5 weeks will not matter.
I think as audiovestibular physician, I guess sometimes occasionally we get involved in the acute presentation stages. I think that's the way the system's set up, and that's occasional, and it just happens to be that I was involved here. And subsequently, majority of it is from an outpatient-based perspective. So that inpatient stay duration, the care was completely handed over to our ITU colleagues and the neurology inpatient team, who looked after her very well.
So here's a question, if I may put it to Sudhir. Sudhir, if a patient like this came, would you take a CT scan at the first pass in India, or would you go for an MRI in the first pass?
I see the aneurysm is extremely rare, to be frank. I have never seen an aneurysm affecting the ICA territory. And therefore, my first suspicion would be an infarct, and I would have gone for an MRI. Which, of course, the MRI would also show bleeding, and then that would raise the suspicion of looking for an aneurysm. But yes, I mean, I wouldn't do a CT, because if it was an infarct, the CT would be normal in majority of these cases, and we would have got misled. So for us, Dr. Arun, it's quite easy to get an MRI within hours. So we usually we can get it done immediately. And it doesn't matter whether we do a CT scan or an MRI, the cost is not really too much different.
Yes, and I think that's a huge advantage, absolutely, because we do have a genuine problem. I think recently we looked at some data which will be showcasing about the use of CT scans and inappropriate use of CT scans. The pickup rate in infarcts, particularly central vestibular infarcts, is about 9% or less than that. Yes. So it's pretty much pointless doing a CT scan in most cases of acute vertigo, but because of the system limitations in a service which is stretched, it does mean that's the first line go-to imaging, unfortunately, in the UK MRI, at the moment.
Even an MRI would be only 88% positive, and correct. People should remember that just because an MRI is normal. Somebody was telling me, even in India, many people think that just having a normal MRI means you have ruled out a central cause of in an acute stroke. So David Newman-Toker has done a good study earlier in the HINTS protocol, and we all know that MRI is only 88% positive, But if you do the hints evaluation and what is now called the hints plus, so this patient would have a head impulse positive, but she also has hearing loss, and so that is hints plus. In an acute vestibular syndrome like this, if you have hearing loss, you must think of an icaterator. You cannot think of labyrinthitis or vestibular neuritis because that would not have hearing loss. So, MRI 88% positive, but hints plus will be 100% almost.
But provided it's done accurately, I think it's the
Yes.
key thing here, which is being a point of discussion amongst many papers and sort of scientific communities.
Yes, head impulse testing is pretty difficult, and you have to learn how to do it.
So the follow-up question to my first question, Sudhir, is that if you had an MRI which did not show findings, when would you like to repeat it if you feel the patient is still symptomatic?
So that's a very nice question. Sometime later, I'll show a case where the person comes with a stroke. Your hints evaluation or your neurological evaluation suggests it is not labyrinthitis, it is a stroke. For example, you might find head impulse negative, or you may find skew deviation, or you may find a little changing pattern of nystagmus or upbeating or downbeat. So your clinical examination suggests it is a stroke. You do a 3 Tesla MRI, it is normal. You do an angio, it is normal. I have had a patient where this MRI was repeated after 48 hours. The patient had come with upbeating nystagmus and was in another hospital. And then they were thinking of Wernicke's encephalopathy, etc. But I saw the patient, he had very sudden onset dizziness, upbeating nystagmus. So the rule is that you must repeat at 72 hours. And
yes,
at 72 hours, when we repeated, it showed a tiny infarct in the pontomedullary junction. So small posterior fossa infarcts might not be seen up to 72 hours. And you have to remember that before you send the patient out as query migraine, because this is not vestibular neuritis. If somebody comes with an acute vertigo, you do a head impulse, it's negative, and you do an MRI, it's normal. Before I send him off as migraine, I will repeat the MRI at 72 hours, make sure there is no infarct which was not seen on the first MRI.
And so now let me shift back to Arun. Would you have that ability to repeat these tests after 72 hours, or would the patient go automatically into a waiting zone?
I think in terms of within the UK system, listen, you'll get a CT head, and if they suspected that you have an acute infarct, particularly a small posterior circulation infarct, you would have to end up being admitted as an inpatient overnight, and emergency MRI scans are relatively hard to get. So by the time it happens anyway, it'll be at least 24, 48 hours. So that kind of works to a certain extent in a very convoluted way to essentially get it within that time frame that you require.
But could you order a repeat?
Just to rub it in, Arun, when we do a repeat MRI, we would only do a flare and diffusion study, and that will cost us only 2,000 rupees. So maybe something like 20 pounds or something. So
yeah,
it becomes quite easy to get it done because we are just repeating one section.
Absolutely, and I think that's a big advantage to be able to accurately diagnose these patients. So actually, diagnosis rates of small posterior circulation infarcts are pretty poor in the Western world. I dare say. I'm not sure how it is in America, but certainly, the Western system in terms of Western European system certainly is lacking.
So to push the discussion, which is quite interesting, a little further, when you do an embolization, and this is to Sudhir,
yes,
how quickly do you expect arrest of progression, and when do you put these patients into a rehab zone?
I think we might have lost Dr. Sudhir.
Sudhir, are you on? Vishnu,
connection difficulties.
I'll connect with him, sir.
Yeah. So, I mean, the question is, when you treat a patient, and you can't expect immediate arrest of the symptoms, there would be brain edema, there would be a period wherein the patient would apparently worsen before he stabilizes. So I'm just trying to get a sense, because these are cases we don't treat routinely, as to how much would be the time interval we are grappling with.
In terms of the acute setting, you don't have much time at all. You'll have edema, you'll have increased intracranial pressures. So if it wasn't for the fact that this young lady was actually within the emergency department by that time, the outcomes would be a lot worse, because here they were able to, and this is the ideal case scenario, where they were able to minimize the downtime where the acute reduction in GCS happened, which is probably the tipping point where where edema and everything was setting in. And I have to say, that part of care in the UK system is second to none. The ability to ensure that all the various parameters are appropriately controlled and the appropriate medications are given in a timely fashion, and that endovascular intervention was performed at a very early and a swift stage, was actually all gold standard. So yes, we can't really argue with them when it comes to a small stroke.
I was just trying to get a sense.
But they were very good with it.
I had to go out for a minute because my dog was disturbing here, so I had to take him out.
Okay, so Sudhir, briefly, in your experience, if you get a patient with ICA and you refer him or her for embolism, what time frame are you talking for the patient to get stabilized and to be put into a rehabilitative mode?
So, like I said, I would talk more about ICA infarct rather than embolization, because I've not seen a patient of aneurysm of ICA territory coming with this. I've seen a number of infarcts. And they once we discharge the patient, maybe by day 4 or day 5, the patient would go into rehab immediately after that. Because like with vestibular neuritis, we all know that the sooner you start rehab, the better the results. Otherwise, often they end up with triple PD-like syndrome.
And can I ask a quick question, Dr. Sudhir? From your perspective, for the infarcts, the small infarcts, what's your cutoff for thromboembolization?
I have done, actually, you are talking about intravenous thrombolysis.
Yes,
Yes. So intravenous thrombolysis, I've managed to do only for one patient. Now, we have to sort of assess that if I don't thrombolyze, how much is the deficit going to be? So if you think that the person will not be able to walk or climb up a stairs without support, or if it's a Wallenberg syndrome and the person has dysphagia and things like that, it is better to, I would thrombolyze. So we have thrombolized the patient with a normal MRI because the patient did not have the things at that time, but only the hints plus hints evaluation suggested that this is not labyrinthitis. And we went ahead and did. Now, you might occasionally thrombolize a patient with migraine, but then when you thrombolize somebody with a sort of stroke mimic, the chances of bleeding are very small. So again, it's safer to thrombolize rather than not do. But like I said, this happens quite rarely because most acute sort of physicians will not be so confident that if the MRI is normal, to still thrombolize.
Absolutely. Okay, thank you. And what's your current first line drug at the moment from your perspective, Dr.
First line, sorry?
First line drug for thrombolysis.
We use tenecteplase now.
Okay.
So
thank you.
It's cheaper. You can give it as a bolus, and the overall complication rate is less. So we give a lower dose, around 15 mg or so, but tenecteplase works out cheaper, and it's just a bolus. So we don't have to give it like an infusion that we used to give with Actilize.
Yeah, so that's really useful to know. Thank you.
So, so let's go to the second case, but just one question Okay, the rehab. Fine, go on. I wanted some questions on rehab. Go ahead, please.
Actually, no, I just realized there was probably 2 more slides on that first case.
Go ahead.
So this was the video head impulse test post. I think this is about 4 to 6 weeks later, so not the initial phase. So what we have is clear development of catch-up saccades, which is occurring, and I'm sure that would have improved. We don't have any sequential ones, but that was in the early rehab phases. Again, quite a nice example. And her eye movements following rehabilitation is always something which I was impressed by, because you can see the difference of neuroplasticity and I guess neuro rehab, as well as time, how much of a healer it is. So she's still got that mild gaze evoked nystagmus and that slight upbeat, but overall, this is a few months down the line. It's not bad at all, and she was making good progress. So I was very impressed by the progress she made.
Also improved? The facial palsy?
No, the facial did not improve. No, that's one thing which, despite rehabilitation, never made any difference whatsoever. Although I think was she able to close her eyes? I think I'll have to go back to that case.
This video shows that she wasn't closing the eye.
I mean, certainly in that case, no. Yeah. So, and then this is case 2.
So let's just stay with this for another 5 minutes.
Of course.
What was your rehab regime, if I may ask?
So we have, well, very lucky, should I say, to have some of the best sort of neurophysiotherapy teams available to us, who's very much interested in both vestibular rehabilitation as well as neurological rehabilitation. So it is a combination of both the actual vestibular rehabilitation type of exercises, as well as overall general balance rehab and facial nerve rehabilitation. So it is something we, generally speaking, tend to hand over to our physiotherapy team, who are dedicated and do take some time to get the patient back on their feet. With regards to the auditory rehab, she did require a cross hearing aid, so we actually fitted her with a cross hearing aid to help her. She works as a teacher, and so to help, for example, when a student comes to her affected right side, she can hear on the contralateral side to help with that. We had to think about a short course of antidepressants to help with the mood, and I think it did help elevate things a little bit. And then she came off those about 6 months later. So we really did look at it very much from a holistic perspective of not just the physical aspects, but also the psychological aspects and the everyday functioning aspects in order to get her back up to her feet.
So the last question here, and this would be to Sudhir. Sudhir, in your crowded practice, if you had a patient like this, what would you really do practically for rehab?
For the rehab?
Yep.
Okay, so the patient has got both a combination of cerebellar as well as vestibular. So I would give the rehab which we do for vestibular neuritis, that is, look at a point and shake your head, move your head, those type of exercise. Of course, the eye ones. And then once that initially that part is better, we would also start all the pursuit, because I'm sure she would also have abnormalities of pursuit and other things because of the cerebellar component. So you will have to give everything. We'll have to teach her how to balance, how to walk, how to improve, use your vision for improving your balance, and so looking at a spot and bringing your feet closer and closer together, etc. So it would have to be just a general mix of all the rehab that.
And would you land up doing it yourself, or do you have the luxury of a separate team?
No, I have a. What I have is we have a device which measures the. It's like a thing which we put on the legs, which measures the amount of sway there is, and then we measure the sway on standing, on closing eyes, on standing on foam, and it gives you roughly how much deficit there is in the somatosensory component, how much deficit there is in the visual component, and the vestibular one. So vestibular, of course, like we know how to tackle, but often many people get a visual problem also. I mean, though their vision is fine, when you do the testing, you find that they are relying less on their vision. They're relying more on somatosensory. And so it becomes easy to teach them how to use vision. You just put a dot in front, and I have somebody whom I've given a set of exercises, and that lady will explain that. So I don't have a good physiotherapist who will teach it. So I have had to devise those exercises and then give it to them.
Yeah, so I mean, while you were being self-critical, Arun, I think here we do simultaneous multitasking, and we have our own set of scripts.
Yeah, we have our problems. We don't have good rehab.
Yeah, yeah.
Okay, right.
Okay, so go on with the second case.
So I've titled this case, "Is it really vestibular migraine?" Because I guess it's again a very interesting case, a case which mostly presented in the outpatient setting. Again, unfortunately, I don't think I made many friends with this case, and unfortunately, Dr. Sudhir might be neurologists who I've upset this time. So I'll tell you all about it. I really did pick them this time. So this is a 40-year-old lady. She's mother of two children. She does have a husband, although she does take a lot on herself. She has a background, long-standing background of vestibular migraine that was diagnosed in like 8 years ago or thereabouts when I first saw her. I'm not quite sure who diagnosed her with vestibular migraine. That's one thing we never did get to the bottom of. And she was treated in the past with amitriptyline, although she's one of those new age people, as we call them, who don't really like medication. So by the time I saw her, she definitely was not taking amitriptyline. She also had this diagnosis of temporal lobe epilepsy. And in fact, the referrer to us was from the neurology epilepsy clinic at our center. And they had the referral previously from a tertiary hospital. So tertiary hospital, I guess a primary care hospital to a tertiary center for a further opinion, and they referred on to us. So that's the story. She does have this diagnosis of temporal lobe epilepsy, although her EEG was normal, just something like that. I'm not an expert in epilepsy. She was advised to take sodium valproate, and as I was mentioning, she's one of those people who's not keen on medication, so she ad hoc takes it. Not sure what's the point of that. She does continue to get intermittent seizures at nighttime predominantly. She feels that stress might be a trigger. She keeps biting her tongue. Anyway, I thought I'd give you the full background because other than that, she was a complex patient anyway, and she has this postnatal depression and stress as well as long-standing anemia. What did she present to us with? Well, she has had progressive symptoms of dizziness, imbalance, nausea for several weeks, which is constant pretty much for the last 6 months, but it's been getting progressively worse. In association, she had this headaches, fatigue. She did describe quite clearly diplopia with movement, and she gets episodic vertigo. She gets dissociated nausea. She does get photo and phonosensitivity. She gets that typical bilateral oral fullness lots of our vestibular migraine patients do describe. She got tinnitus, and but all of that combined together, I guess everyone thought it was vestibular migraine and referred it to me for management of the vestibular migraine. Which is where the story starts. Because ultimately, when I sort of also delved into the history a bit more, she reported all sorts of other difficulties. And she was generally a person who was very anxious, who was describing me. And if you mention something to her, I don't know if you get those patients, but you mention something to her, they'll hold on to it and they'll have that symptom as well. But she did describe quite clear coordination difficulties, pen typing, combing her hair, and the one part which I haven't mentioned is occasionally she felt that her voice dictation software wouldn't understand her. So is it something to do with dysarthria? And then that's again was an interesting point in the history. I'll go on to the examination findings.
Before we go on examination, I want to know the history. Are these episodic symptoms or are they continuous?
So at this point, for the last 6 months, they were continuous. Initially, they were a bit more episodic. And when she was diagnosed in 20, whatever it was, 8 years ago, before I first saw her, it was semi-episodic. I guess she had symptoms quite a lot at the time, but they would come and go. So I guess that's where the diagnosis of vestibular migraine came from, although subsequently hasn't really been explored until more recently because of the progressive nature of the symptoms.
I would not accept the diagnosis of vestibular migraine in a person who has persistent symptoms like this. It is something progressive, and I would like to look for some structural problem. It's unlikely to be migraine because migraine would come in episodic attacks of headache, attacks of dizziness. Of course, the dizziness attacks we know can be sometimes lasting seconds, minutes, hours, maybe, rarely days, but not continuous. So our antenna is up already. Let's see.
Can I open the discussion up at this point to a slightly off tangent at all? Do we have time for that, Dr. Ravi?
I don't think we have time, so maybe you could go on.
All right, we'll come back to that. Only because I was going to ask, do you believe in chronic vestibular migraine? But that's possibly off tangent to a different question.
I don't believe. Most of these patients who have chronic migraine vestibular would be now reclassified as triple PD.
That's right. That's right. In terms of the actual terminology, absolutely. So, examination. We did a cover-uncover test, and I've never been very good at these, I'll be honest with you, but there was a skew deviation in the vertical plane, and that's how I described it precisely. Next thing is, again, and immediate, and at the first presentation, unfortunately, I think I was so fixated with the ideas that I forgot to take some videos of her, but I do have some videos of her later on. But in essence, she has a bilateral gaze-evoked downbeat nystagmus, even with visual fixation. So again, it's smelling slightly unusual in terms of it doesn't, we've got central signs present with visual fixation. And when we sort of had a look a bit further, again, we started noticing slightly more central signs. And as I mentioned, I'm not a neurologist. I do a partial neurological examination, but not a full neurological examination, which is where we work closely together with our neurology colleagues. But bearing in mind that this person came from a neurology clinic, I did start doubting myself because, you don't want to go against anyone else's assessment. But I did notice that her pass pointing was present, and it was a bit worse on the left. She did have this intention tremor again. It was a bit worse on the left, and she's right-handed, so it's neither here nor there. Her gait was very interesting, and I don't think we had consent eventually to record her gait, but she was very functional. She was one of those people who would walk down and she'd be swaying everywhere. And this is a actual representation where you would tell her to walk and she'll literally throw herself everywhere. And it was very obvious that it was functional. And hence, were we able to do a full-blown balance assessment? The answer was no. And as always, my saying is that no one walks out of clinic without positional testing. And when we did positional testing on her, she had positional downbeat nystagmus, and again with a torsional component. And every time we repeated it, it would change. It would sometimes be downbeat, it sometimes be upbeat. So it was very much a range of interesting central signs, some of which I will demonstrate in a short while. And any thoughts at this point, Dr. Sudhir or Dr. Ravi?
I would be worried about something like multiple sclerosis because it can have super added functional components, and the gait being functional can still be because of her thing. Often some patients with organic illness develop something functional because they feel that they get more attention from the doctors. So that is not, when you find somebody with functional, it does not mean that there's no underlying. In fact, having an organic illness is a risk factor for getting functional disorder. But some of the things cannot be functional. The skew deviation that you so nicely saw, the gaze-evoked nystagmus, that cannot be functional. So she has something central going on. Since it's progressive, I was first thinking, could there be some tumor or something? But this does not fit into any tumor-like thing, acoustic or anything. She's too old for a pontine glioma or things like that. Therefore, I would think that probably is multiple sclerosis, though she has never had any history of optic neuritis. But that would be my first choice. And then, of course, some other pontine or some lesion there.
Thank you for that. And I think, can I say thank you for also actually understanding the patient, because I think that's a sign of a true expert when they understand the patient. I've had this conversation with people. The reason there is that functional component, particularly in this lady, absolutely, is because I don't think anyone believed her, and she felt like she needed to put on something extra to show that there's a real problem, whilst overdoing it to a certain extent. So I think that just goes on to show that actually she wasn't believed up to that point. So absolutely. So we did stick on the video Frenzels on her, so maybe not videography, the video Frenzel goggles. Yes, and this is so yes, again that confirmed downbeat nystagmus in all planes with and without optical fixation. We've got a second degree right beating nystagmus. And we did head shaking as we always do, and again showed downbeat nystagmus with a torsional component. It keeps changing, and this was the other sort of key thing with her, is this: there was a lot of changing nystagmus in her case. There wasn't anything always consistent, which was again the interesting part in her presentation. So every time we did the whole pike, it would be a slightly different nystagmus. And sometimes when I describe it to the neurologist, they'd be like, well, no, it's the other way around. But actually, they also recognize that it kept changing all the times. We did do a vibration-induced nystagmus test, and that again was normal in her case. So it didn't actually, sometimes that's quite good at revealing some central pathology, but in her case, it didn't really reveal anything more. So pretty much the same findings as what we found on clinical examination to a certain extent. Should you want to see it? So this was actually not immediately. This was a bit later, so it wasn't as florid as when I first saw her, just to bear that in mind. And I thought I'll show you an example of the smooth pursuit that we got. So this was downbeat nystagmus with broken smooth pursuit all the way across both. It was pretty symmetrical. Saccades were actually pretty good. In fact, it wasn't, there was no hypermetria or hypometria. I didn't put it on here because it wasn't particularly exciting, and I thought in the interest of time. But if we do have time later on, I've actually got the videos, you can go through them. So this is at slightly higher speeds. You can see she really has difficulty tracking with a combination of the downbeat as well as the broken saccades, broken smooth pursuit, apologies. And then we did the head shaking, and again, this is the head shaking maneuver, which I put in because this wasn't in the initial acute florid phase that we saw her, but she still had some signs, and we eventually got her around to recording these things. So we'll see, we can skip through that head shaking part, because, and again, what it provoked was a downbeat, but also a few right beats of nystagmus. So there may well be a peripheral component there as well, as what I thought based on that. So clearly a combination of central and peripheral pathology, which again added to the intrigue of the case. So we do have again a good vestibular testing setup. I guess when we saw the patient, here now we've developed our protocols a bit further, but when we saw the patient, it was predominantly based on the rotational chair paradigms, where we did sinusoidal rotation, impulsive rotation, subjective visual verticals, and the eye tracking, I guess, tests. And it basically confirmed what we saw on that video, which is saccadic smooth pursuit. First degree nystagmus to the right was a bit more obvious, although, you know, it said anywhere between 1 to 4.5 degrees. So it does vary. And I think 2.2 degrees or more is probably when I'd start taking an interest that it might be significant. Sinusoidal rotation did show evidence of abnormal phase lead, as we call it. So that again indicates that there may be some asymmetry going on, but impulsive rotation certainly did show a clear DP, a directional preponderance, with the right being stronger than the left, which again might fit into the actual the findings that we had on head shaking maneuver with right beating nystagmus. Although I guess it's debatable. But in essence, otherwise, nothing too exciting. And that's all we had in terms of vestibular testing. But ultimately, at this point, I was mostly worried about, is there some sort of central lesion? And so what did we do? Immediately. So the first thing I did was, well, listen, just in case it's some sort of BBPV, which is just odd, and BBPV can always coexist with everything else. We always do. I have this habit of doing a repositioning maneuver in the hope that it gets better, but it didn't. Imaging. So, and we'll go through all the imaging that I organized, but I also organized blood tests, including autoimmune, infectious, paraneoplastic screen. I have a list, shall I say, which was handed to me by my trainers and tutors over the years, which I refined, which is quite useful when I see patients with complex disorders. So I requested the whole screening range of blood tests on her. And she was keen on physiotherapy, but she wasn't very keen on medications. So we went ahead and went down that route, although I did suggest that she restart the amitriptyline. So investigations. And I've listed all the normal investigations so far, apart from the hemoglobin, which was just an interesting thing, because ultimately the reason I put down all the normal investigations is because she had the whole works. She had the MRI scan, we had a look at the inner ears, and this is when we started also getting a neurologist involved in the entire discussion, and they really wanted to make sure that they investigated everything else. So she had the MRI head with gadolinium, the DAT scans, the PET scans, the auditory brainstem response, and the blood test was, of course, something which I'd requested initially. The main thing that came back was the hemoglobin, which is pretty low, so she was treated for that. But was that a by the by? Has it got anything to do with the underlying condition? To this day, we're still, the jury's still out. So the next slide will hopefully be the giveaway. Any sort of thoughts or suggestions at this point to both our esteemed panel?
I would say go ahead and raise that veil also.
Maybe autoimmune, some autoimmune.
Yes. Absolutely. As he was just mentioning, unfortunately, I pressed the button too soon. Dr. Sudhir was absolutely spot on. Autoimmune, encephalitis. So we, as part of the entire screen, GAD antibodies was one of them. And GAD obviously stands for glutamic acid decarbolase, is it? And is involved in the conversion of something to GABA, basically, and I can't remember the exact pathways, but GABA is obviously involved in the inhibitory pathways of the brain, and it is a crucial thing. But in fact, that was the clincher when it came to the diagnosis, because that was hugely elevated. And I always remember the letter I got back from the initial neurology consultation. And actually, I'll tell you the full story. She ended up in the emergency department in between me getting this result and me referring to the specialist movement disorders, a neurology consultant.
Did she get epileptic seizure or something?
She did. So remember, the back in one of the initial presentation was that she had epilepsy. She came from the epilepsy clinic, and which left me in a bit of a predicament, because I had to go from one neurologist within the same hospital and department to another neurologist. And in between, she ended up under the care of a third neurologist as she presented acutely with an acute exacerbation to hospital. And, they put together all these results. And I still remember the letter I got back were rather, I think, mildly, there was a line which said, I still don't understand the rationale for doing these GAD antibodies and why they are elevated.
Oh, I think it's an amazing pickup, and it's a fantastic case.
I think, and so I was rather, cautious approaching the case subsequently. But as you can see, I did get myself in hot water at this point.
But did she respond to autoimmune therapy, rituximab, or what was she given?
So she actually ended up having. So I'll go backwards. So initially, so the obvious answers for this is she did actually end up having high dose steroids initially, and I think they managed to convince her because she was medication resistant, and then she underwent plasma exchange, and she the first time I think in years she went for the longest period without seizures, and her gait started improving, and her her eye movement started improving. And I dare say those eye movements that you saw earlier was an improvement to what we saw initially. So that's when I managed to capture those eye movements.
I'm really sorry, but I have to jump. There's another webinar I have to attend.
Oh, of course.
But
okay, so let me ask you one question before you go.
Yeah.
How often do you have to order these kind of investigations in Vertigo?
No, again, both cases that Arun showed are very unusual and very rare. I have not seen an autoimmune encephalitis present with this sort of vertigo-like syndrome. There is something called Bickerstaff encephalitis, which could cause a brainstem syndrome, but usually they would have some diplopia and more of ophthalmoplegic syndrome. So, excellent case.
So, in essence, as we discussed, and I think to briefly summarize,
can I leave? I'm sorry.
Of course, no, please, absolutely. Thank you so much. I really appreciate your time, and it's been a pleasure.
And your expert comments.
Thank you.
And
bye. Good night.
Hopefully we'll meet soon face to face,
Yes.
Doctor.
I'll go to ask your number. I loved your case.
Of course.
Thank you.
I'll connect
of course,
you.
please. Thank you so much.
Connect them. Don't worry.
So I'll just summarize and maybe bring it to a close with this.
Sure,
but in essence, all her symptoms starting ranging from the neurological side of things, namely the epilepsy, the mood disorder, the imbalance and the progressive nature of the dizziness, her eye movements can all be explained by the anti-GAD antibodies that she long had for a long time, but obviously things had gotten to a stage where it got worse. So actually, sometimes, whilst I managed to maybe upset a few people, I still think to this day, hopefully I did the right thing by getting her down the right pathway. So the patient always comes first, and that's who we owe our ultimate loyalty to.
True.
And I'll wrap up there at this point.
So I think I'd say a few words here. I think the take home, especially from your second case, is that as far as possible, we go back to what we were taught, try to bring in all symptoms under a single diagnosis. Try to avoid making multiple diagnoses for a set of symptoms. Number one. Number two, we'd start with the assumption that the patient is always right. I think these would be two messages which at least I take home from your presentation. I think this was fantastic, and I thank you, Arun, for sharing your work, and we hope to be able to receive you again after a brief interval. If you have a stack, then we can see you more frequently. But if you'd like to spend some time and get us interesting cases like this, I'm sure. A brief. I open this out to participants. Would anybody like to ask Arun a question? Please go ahead. Are there any questions from the house? You could either raise your hand or you could put it in the chat box. I think maybe then most ENT surgeons are a little inhibited when it comes to neurological symptoms. I definitely won't.
I think that's probably one of the take-home messages, isn't it? Because ultimately, I'm not a neurologist by training either. The only thing is that I relied upon the actual clinical findings, and I didn't assume anything in this, particularly the second case, which I thought worthwhile sharing.
So why did you ask for autoimmune?
I think the fact is she didn't have any other structural findings in her case, and we, as routine practice, the way I was trained is that actually with these kind of cerebellar findings where there's no clear-cut cause of a structural lesion or anything like that, actually the next step would be to look into the autoimmune and other causes, so paraneoplastic causes. In fact, I saw a paraneoplastic not long ago, which presented with positional vertigo, very typical of BPPV, to the point it fooled me once or twice. And then lo and behold, we did paraneoplastic, and it was a breast carcinoma. So just to and it's just believing in the clinical science and actually having a proper look, and maybe not assuming that what everyone else has done was necessarily the right things, and actually reviewing the whole scenario in the best interest of the patients is probably what I would advocate.
So we have a question on the chat as to why you didn't consider labyrinthitis in the first case.
So I think when we went back to the first case, just to clarify, the patient presented with acute audiovestibular loss, which can be labyrinthitis, of course, but she also had this progressive right-sided facial nerve palsy, which started becoming very apparent.
And
but
plus
as
she
Dr.
collapsed,
Sudhir,
I think, and plus she
eventually,
collapsed.
By the time, I think, it'd been about half an hour when she eventually collapsed. But it's a progressive facial nerve palsy, which was a clear cranial nerve palsy, which indicates that it's a central lesion. And as Dr. Sudhir was saying, actually, if you did have a hearing loss with the acute vestibular dysfunction, it's actually a red flag as far as he's concerned. And I think as far as many people would be concerned, because it increases the probability of it being a central lesion. So in fact, I would have a higher index of suspicion that it's, even if it's presented in isolation, I would still be very tempted to do an MRI scan, even without the facial nerve palsy.
And of course, you have a question on what are the investigations you recommend for an autoimmune disease?
That's a very good question. This was handed down to me, and I think it involves a range of antibodies. In fact, you can probably Google them, probably beyond the scope of this. I myself just hold on to a list which was, I guess, taught to me.
I think this is the importance of following a fixed protocol.
Yes, absolutely.
I think an algorithm-based treatment is always safer, because the likelihood of missing if you're doing diagnosis and investigations on the fly is quite high.
Yeah.
So I think that is a wonderful take-home message. So I think we've run out of time, and I don't know how to thank you, Arun.
It's a pleasure. Absolute pleasure. Thank you for having me.
Not at all. I think we look forward to continuing this interaction, and to all those who would like to touch base, we'd be happy to connect, and we would also bring out an e-magazine on this discussion with some further details and maybe some more inputs. So good night to all of you all, whichever part of the world you are in, and stay safe. Au revoir, Arun.
Au revoir. Have a lovely evening, and take care, everyone. Thank you for joining.
Bye.
Thank you for having me again, both to Cyclops and Dr. Nair and everyone.
No, thanks a lot. And thanks, Vishnu, for giving us a very good back end. Thank you.
Bye.
Thank you, sir. Thank you.
Thank you, Arun. Bye.